So I'm here for the management of advanced oral cancer, and this is what my country brings in: oral cavity, huge lip cancer, buccal mucosa, maxillary tumor. So they are very difficult ones as compared to the oral ones. So this is the most common cancer in the males in India, which is 16.1 lip and oral cavity, according to the Global Call 2018, as well as in all ages, lip and oral cavity is the second most common cancer, which is 10.4% of all the cancers. And the mortality of these lip and oral cavities actually more than 50% of the incidence. And if we compare stage 3, stage 4A, and stage 4B and C, out of 120,000 patients, 190,000 patients, more than 120 or 130 are stage 3 or 4 beyond. So this is a retrospective analysis of around 5,000 patients from Tata Memorial. 80 to 90% of these cases are stage 3 or stage 4 malignancies. And this is comparison of Western versus our population. Our survival rates are less, certainly less, 39% versus 24. In oropharynx, 33 versus just 14. So this is a comparison of Western versus Indian data. Our survivals are less. So our habits are also different. So this is my favorite slide, which says cancer cures smoking. So when we ask our patient, when have you quit? They said when the diagnosis has been made. So cancer quit smoking. So we have different forms of chewing tobacco, smokeless and smokeless form of tobacco. We have a habit of pouching tobacco in our gingival buccal sulcus, various form of smoked tobacco in the form of cigarettes and BDs, the crude BDs. So we are no less in HPV. We have huge Indian data of HPV, the oral cavities as low as 6% of oral squamous cell carcinoma. So when I was at AIMS, it was 22.8% of the oropharyngeal cancer with Dr. Alok and Dr. Atul sir, and larynx and hypopharynx to the tune of 5 to 20% across various studies. So the issue relevant to the management of locally advanced oral cavity, how to choose wisely, and what is that wise, and what is to be chosen from. So investigation, how much Devrath has clearly told: CT, MRI, PET, CT scan, along with the clinical examination. The most important is the borderline resectable, the unresectable ones, and the recurrent and metastatic. These are, mind you, these are aggressive malignancies with very high rate of recurrence. So a tri-modality approach involving both surgery, radiation, and chemotherapy gives us that survival benefit. So pre-treatment investigation, well done by my previous speakers. So good thorough clinical examination, preferably by a surgical oncologist or an ENT specialist, and a combined pre-operative assessment of by all the three modalities: surgery, radiation, and a medical oncologist, as well as serious assessment of the comorbidities, which is huge in our country: the diabetes, obesity, smoking habits, COPD, the speech and swallowing function, the nutritional status of the patient, the dental and the psychosocial evaluation. They are all very important apart from clinical staging as well as investigation. So we have to see this aspect in our country as well. So Devrath has clearly said that out of all three, there's no difference. So we prefer CT scan or preferably an MRI, a chest X, and ultrasound. So PET CT is sensitive for identifying occult node other than CT and MRI. Otherwise, all three are same. So who should have surgery and when in locally advanced? In resectable, it should be always surgery first. In borderline resectable, it should be chemotherapy first or chemoradiation first, followed by surgery. In locally advanced or unresectable, it could be induction chemotherapy or chemoradiation. And in metastasis, no surgery. We have to follow a palliative approach for these patients. So borderline patients, so various of the Western studies, they have included oral cavity patient, which was in the tune of 17 to 20% in various TAX 3 to 3, 3 to 4, or our DECIDE or Paradigm study. So the induction TPF, so particularly in Indian setting, it's a difficult one. First of all, you have to choose to select a very fit patient who can take this good dose dense therapy. Use of centers which have appropriate experience of this PICC line, chemoports, patients staying in for 6 days, continuous infusion, the pump going wrong in the midnight, well-functioning multidisciplinary team, long-term outcomes, and especially the management of those febrile neutropenias. Your emergency should be well equipped when they land up 2 a.m. in the morning with febrile neutropenia and sepsis, and we all of has had mortalities with TPF. So this was Indian experience of neoadjuvant chemotherapy in borderline resectable. It's a Tata Memorial study. So it was by Dr. Patil. So 123 patients, So they've given 3-drug regime and 2-drug regime. 2-drug regime was more favorable because of the logistics, daycare admission, no inpatient admission. So only 3-drug was given in 26 patients and the 2-drug was given in 97 patients. So, oh, sorry, skip. Yeah, yeah. So it's moving on its own. So the response rate at the end of 2 cycles were, the partial response rate was 30% and the stable disease was around 50 to 60%. And the resectability achieved after 2 cycles in 2-drug regime was around 40%, 37.9, as well as 70% if 3-drug, although the 3-drug patient number were very less. So this was again a study from Tata Memorial, a huge retrospective analysis of 721 patients, neoadjuvant chemotherapy followed by surgery in very locally advanced, technically unresectable oral cavity cancers. So 721 patients of stage 4 oral cavity, 3-drug regimen given in just 10% and 2-drug regimen given in around 90% of the patient. And they could see that the resection, around 43% of these unresectable oral cavity cancers were able to undergo surgery. And this, the Kaplan-Meier clearly says that the overall survival of the patient who got surgical resection post-induction chemotherapy versus non-surgical treatment, any treatment, it was significantly better. And the overall survival of surgical resected induction chemotherapy and those who have received further adjuvant treatment, the survival was better to those who have not received any adjuvant treatment. So in this study clearly shows, although it was a retrospective one, that the unresectable, 43% of these patients who were unresectable can be converted by a surgery, and further adjuvant treatment can actually increase their survival. And this 2-drug regime of paclitaxel carboplatin or docetaxel cisplatin is sufficient, so we can avoid the 3-drug regime, particularly in Indian settings. So it included finances, unwillingness for the prolonged admission from the patient side, and inability of follow-up OPD every week, so every 3 weeks. So this favored 2-drug regimen as compared to the standard TPF regime. So another concern is concurrent chemoradiation in our country. So the data says 3 weekly, we all do weekly. So there was a randomized study again from Tata Memorial Hospital which says that the weekly regimen of cisplatin when compared to 3 weekly, it's debatable. The dose of weekly was just 30 mg in their study. So they said that the cumulative loco-regional failure was higher in weekly cisplatin as compared to 3 weekly, but this paper has to be dissected very well to understand. So cisplatin is associated with various toxicities which are early and late one in the form of nephrotoxicity, xerostomia, hematological toxicity, dysphagia, ototoxicity, and so on. So we have to identify our patients, those who are suitable for cisplatin, those who are high risk for cisplatin, and those who are contraindicated, because our patients are elderly at times, they're diabetic, have COPD, have some amount of LVF or right ventricular failure. So we have to identify which patients of ours are cisplatin eligible or not eligible. So cetuximab is the drug. So now we are talking about Indians choosing wisely the which wise drug. So cetuximab, so average cetuximab cost, 1 month cetuximab is close to $6,000. So it's a huge burden if our patients are not able to take standard cisplatin. So we have further options like going for carboplatin 5-FU, or radiation alone in such patients. So we have plenty of Indian studies which have combined cetuximab and radiation, and the DFS and OS was comparable as to the Bonner study. Another drug which is not very well talked about and discussed is nimetonzumab. This is also anti-EGFR drug. This was Govind Babu study or BEST trial done like 7-8 years back, which says that concurrent chemoradiation, cisplatin and nimetonzumab had a survival benefit if compared with only cisplatin and radiation. This was a Tata study of nimetonzumab which says that nimetonzumab added to cisplatin is better than cisplatin radiation, and there was a PFS benefit, although there was no OS benefit in this study. This is our data of Max Hospital, where we had 35 patients of nimetonzumab combined with cisplatin and radiation, and we had 100% response rate, 97% response rate in these patients, although majority of them were oropharyngeal. Coming on to the recurrent and metastatic, so most of these patients, around 50-60% of these patients will have to recur, have to relapse, so locally advanced oral cavity cancer. So we have, so the standard guideline says cetuximab combined with 5-FU and cisplatin in the extreme trial, but we in India follow, we have manipulated this trial. We go ETP regime, cetuximab, taxanes and platinum, or cetuximab with some other agents. So they have plenty of studies which are done in India as well. So which have comparable PFS and OS benefit of 7 months and 10 months overall survival. This is our experience of 229 patients of cetuximab combined with chemotherapy versus chemotherapy alone. So we had a PFS of 8.1 versus 6.1, a OS of 11.8 versus 8.0 months when cetuximab was given to these patients vis-a-vis comparison with only chemotherapy. So our data was comparable to the extreme as well as the other Indian as well as Western studies. So this is the NCCN guideline which says clearly that if patient has recurrent disease or metastasis, so cetuximab combining with any of the chemotherapy arm, which could be cisplatin 5-FU or which could be a taxane and carboplatin. Recently in ASCO 2019, we had a weekly cetuximab, taxane and carboplatin data, which was like superior to the extreme, comparable to the extreme study. Coming on to the immunotherapy, this is buzz in the market. It's approved as a second line. The keynote 148 says that it could be given, but in India, it's a different ball game. We don't have actually the standards. We don't know which platform to use. Our pathologists and even we are not well versed. The DACO one, the Ventana one, how to calculate CPS, how to calculate TPS. So who will train me? I was asking this question in the previous thing. Who will train me? And I'm training myself in these drugs. So we'll have to gain experience in these drugs, and we will do one day. So coming on wise conclusion for my country. So multidisciplinary key is the key to unlock this difficult subset of locally advanced head and neck cancer. Appropriate pre-treatment evaluation is must. Imaging has a more role in this locally advanced as compared to oral cavity cancer. Induction chemotherapy needs more exploration, specifically in unresectable head and neck, the Tata way in locally advanced head and neck cancer. The 3 weekly, we need to be confident as compared to the weekly cisplatin. It saves cost, it saves number of daycare visits. Recurrent metastatic, it should be a very careful selection. Appropriate counseling is required because millions are being spent on this cetuximab and immunotherapy. It's quality over quantity, so palliative care needs to come early. Financial impact needs to be discussed, and immunotherapy administration, how to administration, whom to administer, and various consequences have to be discussed in detail in this part of country. Thank you for your kind attention.